All right, it says we're live. I like to go check in on the book of the face before I actually commit to anything. So hold on one second, everybody. Let's see what we sound like. It's me and Laura. Hi, Laura. How are you?
Hey, Clint. I'm good. How are you?
I'm good. Let's see what we sound like here. Oh, something's wrong. Here we go. No. Yep. Yes. We're live.
Awesome.
We're live.
Let's go.
All right. So, first of all, thanks for coming in.
Thank you for having me.
I know you're super busy. You guys have a lot of stuff, and I'll get this out of the way. You work at Optimize You with Josh Porter and that group.
I do. Mm-hmm.
I'm a patient, and I will say this to you real quick before we set this whole thing up, that women need testosterone too. We're going to walk through what is menopause, perimenopause, mention a couple of the other hormones, just 3 or 4 minutes to give us some background, and then we're going to move into testosterone specifically. Oh, hey, Jen. Hey, one of the reasons we're having this conversation is my girlfriend just chimed in.
I'm not supposed to look here, but...
No, you can look at this.
Hey, Jen.
But one of the things I like about Optimize You is I always say that I'm a patient, not a client. I like that, the view, because there's some places you can go and you can do air quote hormone replacement or these other things, and you're a client.
Right.
I like being a patient. I want to be taken
care of
from a medical standpoint that takes into consideration other stuff. You guys do that.
Absolutely. Yeah. We look at a lot of other markers as well. When a patient comes in to have their labs drawn, we're going to do a comprehensive overview of screening labs, thyroid, your lipids, your hormones, obviously, and then talk about family history, personal history, some of your concerns. And if we can't fix or help what you are having an issue with, we're going to refer you on.
Yeah. Yeah, I don't like it when you ask me about my diet and stuff, though. Just give me the magic stuff. And you're like, that's not how this works.
Yeah. It all kind of works together. Unfortunately, we gotta, put in the work.
I don't like my part of it.
I know. You want that quick fix, right?
Yeah. Well, let's do this. Let's jump into it because people got limited time on this. We are going to focus in on testosterone in women because when we said this before we were talking, when we went live, when I say estrogen, everybody thinks women. When I say testosterone, everybody thinks men. Truth is, we both make both of them.
Absolutely.
And they're both vitally important. But can you just briefly set up perimenopause versus menopause? Are the symptoms the same? Give me your running definition of it so we know what we're talking about.
Yeah.
And then we're going to zoom into testosterone.
Okay, so perimenopause. Well, we basically have 3 stages in a woman's life. We have premenopausal, that's up until perimenopause, when we start to see some fluctuations in progesterone and estrogen and testosterone, and then we move into menopause. And so this whole phase between perimenopause and menopause is more of a transition phase. So it's not as if we go through menopause necessarily, but we go through the transition to menopause. And so perimenopause can start 4 to 10 years prior to menopause, and you're going to see things like brain fog. Maybe you're waking up in the middle of the night. Maybe you have less energy. We see irregular periods. If someone is still having periods, if someone's had a surgical procedure or a hysterectomy, but they still have their ovaries, we can't use that as a gauge. We're also going to see indicators on their labs at times, but not always. Perimenopause is the zone of chaos. So yay, right? That sounds fun. It's not real fun. And so we try, I know, right? Now, we try to buffer that for women and try to come in and make them feel like themselves again. They come in saying, I don't feel like myself, but this can last 4 to 10 years before true menopause. Go ahead.
Just a quick question on that, because I've heard, and a lot of my questions are going to come from, of course, I'm naive about this, right? I've seen it played out around me and the women in my life, but
we're in that phase of life.
Well, thank you very much.
Yes.
But the flip side of it is this based strictly off age? In other words, if I go to my doctor and I'm a woman and I'm 45, they go, oh, you're in perimenopause? Or is it very dependent on the person?
It is very dependent on the person. And, that's a great question because we typically think of menopause around age 51, 52, perimenopause 4 to 10 years prior. So if you're in a perfect world, that's more like 41, 42. But we see perimenopause in the mid to late 30s sometimes, all the way up till, in the early 50s. So it's going to depend on a lot of factors, your overall health condition, the age your mom was when she went through menopause, and then, environmental factors as well. And so perimenopause can start in the mid 30s, but we know by around age 45, most all women are there.
Really?
Mm-hmm.
In that age of chaos.
Zone of chaos. That's right.
All right. So let's talk a little bit about a couple of the hormones we've heard about.
Sure.
Testosterone's part of it. When you start having these symptoms, because you just went through them, what are the hormones that play an important role in getting this dialed in? Because we think of just fix the estrogen.
Right.
But you mentioned these are not siloed things.
They are not. Hormones work in conjunction with one another. It's a symphony. So they don't, we can't just say it's one versus the other. And we'll get into more of that later. But with perimenopause, we see a decline in progesterone. And then we see erratic levels of estradiol. So when you reach menopause, that's when you've gone 12 months with no period. And again, if someone's had a surgery, we don't always know that point, but we use labs and symptoms and age to look at that. And so we'll see an elevation in something called a follicular or follicle stimulating hormone. And that's where the ovaries and the brain are just not communicating like they once did. We see low levels of estradiol. When we see that consistently, then we know a woman is in true menopause. And so if they're having periods, that's 12 months with no periods. And then with that, we see, more brain fog, vaginal dryness, hot flashes, the cardinal sign, hot flashes. About 80% of women have hot flashes, but not all of them do.
Energy?
Fatigue is a huge complaint. It was, for me, it was one of those first things that I was like, I cannot live with this fatigue. It was debilitating.
Because you go through, you lived your life a certain way.
Yes.
If you're healthy and you're very active, you work out and you're used to it. And all of a sudden there's a difference and you're like,
something has changed.
Yeah, there's people that depend on me to keep my energy levels up as much as possible.
Right. Yeah. We see a lot of brain fog. We see a lot of joint pain. So we see an increase in inflammatory markers. So if someone comes in with like frozen shoulder or plantar fasciitis, we know those are correlated with low estrogen levels.
Oh, okay. I didn't know that.
So we see body composition changes. We forget that, but that's probably one of the number one complaints I hear is I've gained weight around the middle. I don't ever gain weight there. Now I've gained weight around my...
I was doing to keep it off.
It's not working anymore.
Even if you're strict on your diet.
That's right. Yeah. You haven't changed anything. And then suddenly you've gained 5 pounds around the middle. So we see that more fatty replacement. Yeah. Well, it happens in men too with hormones. And so that's something we'll get into also about how men and women are the same but different.
Right.
And so with perimenopause and menopause, we see those changing levels in progesterone, estradiol with testosterone. I know we're going to talk more specifically about testosterone. We see just a slow decline decade over decade. And so it doesn't always just fall off the cliff at menopause. Sometimes it does, but sometimes it's earlier.
Well, and I'll say something you can affirm or deny, but to me, it sounds like especially with women, you may have one hormone that has got is the more of the issue. The other ones may be okay. It just takes fine tuning one, and sometimes it's the symphony of all three, and what served you 20 years ago may not be where you need to be now anyway.
That's right.
In a healthy body, right?
That's right, yeah.
Because that looks different.
It does, yeah. I mean, as we age, we know that, we're going to see varying levels of these hormones, declines in these hormones, but also looking at other markers that I mentioned, like your thyroid, like your overall health, other vitamin levels, inflammatory markers.
Do people, when they go to the doctor, and then we're going to jump into the testosterone part, when women go to the doctor, and we'll stick around, specifically because what you deal with, do people forget to check their thyroid levels? Do they forget these other things and just try to find in the hormone? Is that tempting even in your world to kind of go, it could be a thyroid. This could be a thyroid thing too. That's just adding complexity.
Absolutely. I mean, thyroid overlaps significantly with the symptoms of perimenopause and menopause, and we often see thyroid changes during this time of a woman's life. What we do, we actually start with a full thyroid panel. So we're not just doing a top-level screening lab. We're looking at the T3 and the T4, some other parameters around thyroid health that are going to help us rule that out, first of all. And then another thing to remember is when you go into your doctor, they're looking at a large range. So thyroid can be normal, but not be optimal. And so that's where we come in, and we want to look at those levels that not just keep you from being sick, but they actually help you thrive in life. They help you have quality of life. And so that's where we kind of more specialize in that and have a more nuanced conversation around your health and your optimal levels.
All right, so let's jump into the testosterone part of this. I don't know where, I'm trying to figure out whether I want it to be the first question. Let's just do a low-hanging fruit.
Sure.
And let's do a fear.
Okay.
Facial hair and voice.
Yeah.
Because I got that one, and I posted some of the questions I got on the event page. But one of the fears that women may have, or maybe the other one's getting too bulky if they're working out. Maybe not. Yeah. But is that a problem? Is it not a problem? Is it depend? What is your response to that fear?
So I think that if you are going to take testosterone, you've got to have someone that is looking at your levels. We've got to be looking at levels. We have to look at some other proteins in the blood. So when you're looking at total testosterone, you're looking at all the testosterone in the body. So we're also going to be looking at something called sex hormone binding globulin and albumin. These are proteins in the blood that will bind to testosterone. So for instance, a sex hormone binding globulin is just that. It binds to sex hormones. So if yours is low, then you have more free testosterone. Does that make sense?
Mm-hmm.
So that's going to create an environment
Which one
where
do you want more of and less of?
It depends on if you're trying to prevent side effects.
I got the body language.
That's right. I mean, it depends on the way we look at it. We want to give you a benefit without a side effect. And so we're trying to find that point in your physique, in your, looking at your other parameters where you are getting a benefit without that side effect. So we're looking at multiple factors, not just that total testosterone
But is that a
level.
fear? Let's address that fear.
Oh, I don't.
In other words, do you see that a lot, or is it manageable? In other words, a lot of women may not start this because they're scared of it.
Right.
Is a way to put that fear to bed is that it's manageable.
Yeah, and I don't think we go from 0 to 300. We are going to look at this in a low and slow manner so that we know how your body tolerates it. But I don't
wake
really
up talking like me the next day when you started testosterone.
No, and you're going to have regular monitoring as well.
Yeah.
And I think that, there are side effects that can happen with anything we do. Mm-hmm. And there's side effects that can happen if we don't do something.
The reason you're talking to somebody like this is there are side effects of what's going on in their bodies already.
Right, exactly.
Right?
So if we don't do something, we have a result. And if we do something, we can have a result. So dialing that in a very precise way is important. But I don't really see that as a fear in women. Okay. I mean, to be honest with you, most women come in open to
sure
trying.
That question was by a man then.
Maybe so. Yeah. I mean, or maybe someone's experienced that with their testosterone. So if that's the case, then we need to look at maybe a different form. We need to look at how you're absorbing it, where you're applying it. There's a lot of nuances around that.
How to take it. They also could be doing this. They also could be watching influencers
True.
who are on hormone therapy, but they're taking other things too that are affecting.
Maybe potentiating that.
Something that's maybe helped. You used a good word. I was just going to say making it worse, but way to go. How about breast cancer and heart? Now, this is a big one because you were actually on, and Josh has addressed this on the men's side. Is it good, bad, indifferent? Have there been changes legally around the black box stuff on this?
So for men last year, we had the removal of the black box warning around cardiovascular events. Women right now, we don't have an FDA approved product in the U.S. We have it in other countries.
This is where I was going with this.
Yeah. So the regulatory just barriers that we are up against in terms of getting a product approved it's the real deal. Like we really struggle in the U.S. with getting that for whatever reason. But I believe it all stems back to the Women's Health Initiative. The Women's Health Initiative came out in 2002, where there was actually a testosterone product that went up for approval around that time. But there was so much fear around breast cancer, heart attack, and stroke that came from that they grouped all hormones in that increase of breast cancer, heart attack, and stroke, that we now know that there were a lot of flaws in that study. But it has led to those fears to persist against all hormones for women. But there's actually data, to answer your breast cancer question, there's actually data that before we had these modern treatments for breast cancer, they used high-dose testosterone in women with breast cancer to help treat that. Now we have much more advanced therapies now, but there's still data looking at using testosterone in women with Rebecca Glaser, who looks at using that in breast cancer patients or survivors to help improve their quality of life. So, and there's also data just looking at testosterone in general. It works in the breast, it attaches to the androgen receptor and kind of puts a brake on the division of other tissues. It's just that we don't have a drug company that's sponsoring a large trial to look at that. We don't have an approved product.
Well, but I mean, it isn't. Don't these feed off each other? Don't you? Isn't part of getting the approved product part of going through the push and the initiative?
It is, and we do have a company. Yep, we have a company that's receiving some regulatory guidance from the FDA right now, 2026. However many years later, that's going to start looking at a product for the U.S. But I think too, testosterone went off patent in the 1930s. So we've used it for a long time. It's just that we haven't had that push. Now with men, we have 30 plus products for testosterone for men and 0 for women. So we can get in that discussion, which is a very different nuance where we have, we didn't study women in medicine until the early 90s.
Well, so I'm going to jump in on this. And real quick, if anybody's watching and you have a question, you can interrupt us with a question. That's why we're here. A question or comment or thought. That's fine too. But one of the things that my conversations with Jen have exposed around creatine even, a lot of the studies that were happening on how to take it, when to take it, is because those studies were based off how men should do it,
right,
and not women. And so you start finding these little things out about the medical world, is just like probably everything else. A lot of the studies, to your point, have been geared towards testosterone's the man hormone.
Right.
And it is very
primary, right.
It is our lead one, right?
Correct.
But we then can't say it's vital to have this mix of hormones for women and then act like we can just live in a vacuum and it's not important.
Right.
You know what I'm saying?
Right.
And so I don't understand. I mean, I do understand there's money and there's where the focus is.
Correct.
If I'm in charge of the research, I want to fix me.
Yeah.
There's a good dude in charge of the research.
Right. Yeah.
Hey, go fix me.
Exactly.
Yeah.
It's almost like it has to become a problem for us before we're willing to put that behind it. But if enough women are out there talking about this and we're communicating and we're telling our providers, and providers are also advocating for our patients, then, and we see that we've seen leaders in this thought world like Dr. Kelly Casperson, Dr. Rachel Rubin. A lot of urologists are really pushing for these female products.
You see hope on the horizon for this?
I do, yeah. They went up before the FDA in the fall to have the black box warning around vaginal estrogen removed. And so vaginal estradiol is just for local tissue, in the women's genital area to help prevent like genital urinary syndrome of menopause, which is just that dryness, bladder health, atrophy. And so there was a statement made by Dr. Kelly Casperson, hey, let's talk about testosterone to the FDA.
How was that received?
Well, we don't have it yet. Yeah. So, I think we just have work to do in that area.
Is this years down the road, or could this be fast tracked? Because it seems frustrating when I have these conversations with other people, especially women, of course, and they see other people getting prescribed stuff, and then they're the ones that left out. Do you think that there's some hope on this? And then we'll move on to some other questions.
Yeah.
But it's just, to me, it's a very frustrating part that everyone seems to have to go, I have to pay out of pocket. Insurance doesn't cover anything. I can't even prescribe it. I have to, and they're like, I hate to say this, like guys used to, if we're not going to give it to me legally, then we'll go get it somewhere else.
Yeah.
And now we don't know what we're getting.
Right. Yeah. I mean, I don't really know how to answer that, to be honest with you, Clint, because I think the FDA has, I feel like, given promise in recent months where we see more action around hormones, peptides, things like that, where we have some hope on the horizon. So I'm hopeful that we can look at that. In fact, I know they have a lot of other priorities. And so I think it really comes down to, who is the loudest sometimes, who's the loudest, who's pushing the hardest, and then some of the studies and evidence that we have around the benefits of using these hormones in women.
I can't believe that even if dudes were in charge of the research, that women in their lives are not louder than that. Because you would think if I'm going home every night and somebody's like, hey, something over here for how about us?
Yeah.
There's a shout out to the women in their lives.
I mean, I'm sure we can be loud when we need to be, right?
Well, I guess we beat that horse to death. I just think that there should be a little more, to your point, a little more push.
Yeah.
Because it's health.
Yes.
This is not a thing that we wish with it or we're choosing to go through. And this is truly about health. There's many things that I think get thrown under the health umbrella that are more political nowadays. And it frustrates me because things that are truly involving people's health, whether it's men or women, get thrown in there when technically they're real deal stuff.
Absolutely.
It's not stuff that can be political. Let's do this, and I want to get to some of your stuff too, but let's go to some of the questions we had. And I think I've already addressed one. In case you want to hit them real quick, sign of my testosterone levels may be too low. You've already addressed those?
Yeah, let's talk about that a little bit. Okay. So, we think about testosterone in terms of sex drive a lot of times, but really testosterone is a brain hormone. So it works in the brain. So we think about motivation and mood. So things like, productivity, stamina, brain fog, anxiety, low mood, irritability, rage. We've had studies that have looked at mood, and adding testosterone helps improve that mood.
Okay.
So I think that we sometimes pigeonhole testosterone as just like a sex drive hormone, but there's a lot of other things: musculature, strength, the ability to think clearly. Like I said, that brain fog. So those are real problems women face in menopause where they can't articulate their words clearly.
Right. Well, and to your point, especially it seems like research is showing that keeping strong muscular skeleton and just muscle strength is so critical as women age.
Yeah.
It's one of the leading indicators of how good and long they're going to be living, to actually not give more credence to the testosterone and more conversation around that can be difficult.
It is. In fact, while I was getting ready for this podcast, just kind of reading some of the recent data, I came across a study that looked at using testosterone in women who'd had hip replacement.
Mm-hmm.
And it's called the Step High trial. And they looked at older women. These are women in their 70s. And what they were looking at was how far they could walk, like in a 6 minutes. Well, they didn't see improvement when they used testosterone in how far they could walk, because testosterone didn't make them faster.
Mm-hmm.
But they did see they lessened their need for a cane or a walker at 6 months. So we know in recovery, testosterone plays a role. We just need more of those studies.
Yeah.
So we know there's a role for it, and we know it does work. We just need more studies that last longer, looking specifically around things like strength.
All right, so let me do this real quick. Hold on a second. We got a comment up here. And I'm going to go back to another question. Is testosterone safe for women was one of the questions. I think you've addressed that. But let me go here. Good Lord. Do you have anything for eyes? That's what I need.
Actually, it works in dry eyes.
Apparently I need something. I was taking a heart class and had a dissection. The doctors told me because I was taking hormones, must stop immediately. Can you read that question up there for me a little bit? I can actually make it a little.
I was taking HRT.
There we go. Let me get it over here where we can read. There we go.
And had a dissection, and the doctors told me it was because I was taking hormones and must stop immediately. The SCAD research shows it contributes to dissection.
Mm-hmm.
Is there any new information that could benefit menopause and is safe? I would really have to, know more information about her history. And that's why I say, it does take a team approach. We work with your specialist. We want to work with your specialist. And I think it's important to ask their opinion on things like this, because that is a specialty within a specialty to look at cardiovascular health and testosterone. And I'm not sure if that was estrogen, progesterone, testosterone, or just testosterone. But we know that there have been heart health benefits that have been seen with testosterone as well, like the muscle strength of the heart. The heart's a muscle.
Yeah.
So we see more strength with that.
Well, so to the point on this, and this is what we were saying earlier, and by the way, thank you for the comment. And what I would suggest is, I don't know if you have someone, but this may be something we do a follow-up question with, answer, because I like getting answers to people. Maybe there's a study out there or something, but this is one of those things that it's so individual, had no history of heart disease. This is one of those things that can happen in each individual, can be so specific.
Right.
Where me and you, if I was a woman saying, we were identical in everything except blood work that no one can see, you could take something, I could take something, and it would affect me differently. That back to your team approach and the tracking.
Exactly.
It's not we're just going to put you on something and walk off.
Absolutely not. Yes.
Yeah.
We need to look at those levels. Excuse me. We need to look at symptoms. We need to work with your specialist. So if you have a history of heart disease, you really do need to have their buy-in, their support, and not just from their opinion necessarily, but from those clinical studies.
And so what I'll do too, just because I'll reach back out to, because she didn't bring any research in with her. I know there's maybe Josh and your team may have some research to either confirm, deny, or maybe be inconclusive, but I'll make sure, because I know her, I'll send you anything I get from them. I will send you private message and I'll post so other people can read this too. That's the whole purpose of this podcast, because we talked about it. There's going to be some stuff come up.
Yeah.
We just don't know the answers to. But please continue to ask the questions. One of the things I want to walk over to, safe for women, but can testosterone therapy help with libido and sex health? Of course.
Yes.
You've already talked about that. What forms of testosterone therapy are available for women, and which are best? There's creams, pellets, injections, other stuff.
Yeah, those are primarily the ones that we use and utilize. The oral forms, which we don't recommend. Those go through the liver, and it can worsen cholesterol and lipid panels and things like that. So we don't recommend any kind of oral testosterone for women. We utilize creams. We utilize small dose injections and pellets. And it really comes down to consistency and absorption. So however your body is going to absorb that and metabolize it the best, along with what would you be more consistent with? Because if you don't use it, you won't get a benefit from it.
Okay, so and I know you talked about this a little bit ago, but is there an optimal ranges? And when people are looking at their testosterone panels, what are the ones? Because I just look at overall testosterone, free, all these things you mentioned earlier. Are there optimal levels of each?
Yeah,
range?
that is such a loaded question, Clint, because
I kind of knew it.
there are, I'm sure you did. Yeah.
She
Yeah.
gave me the point. Go ahead.
No, it's loaded in the sense that there are mixed opinions. You know, when you read the literature, we know that in the physiologic range, and that's going to vary for each individual.
Yeah.
But that we generally can manage there without a side effect. Now, there are some thought leaders that believe you need to get a little above that. And in some of these studies, like for instance, in the one I referenced around the hip replacement, that level was managed a little higher. And then there's also even higher doses that haven't shown side effects. But we want to look for, again, those binding proteins, your specific symptoms. We also want to, we want to listen to you, talk to you, look at your symptoms and see, is this helping or not? Maybe it's not a testosterone issue. But, maybe we have you managed physiologically and you're still having a symptom. So testosterone is not the cure-all for everything, but it is definitely worth a conversation.
Yeah, and two, you guys you kind of operate on the just because it's normal doesn't mean it's optimal. I'm going to throw out a number, but let's say mine's 400 or 26, whatever we're looking at. That may work great for Clint, but for Tom or for Sally, she needs a completely different number.
Right.
And that's great for her. And to say there's a range, but I asked you that because I know for a fact that people are going to say, I'm in a great range and feel terrible.
And then I would say
as I'm in normal range, because I got that twice message to me. Can you ask why my doctor continually says everything looks normal, but I'm feeling the same?
And this was specifically testosterone.
Well, that's when I put this up there. They just responded to the event. So I'm assuming they were.
So then I would want to look at their free. Are we looking at a free testosterone? Are we looking at a total? So, again, even in the androgen society world and expert world, there's controversy over, do we look at total? Do we look at free? In our clinic, we look at both. And so we want to put that picture together to help patients understand it's not just your total. If you have a high binding protein, then maybe you're not realizing some of that testosterone because it's bound.
And it's not being used.
It's not free. It's not active. It's not available for you to get benefit from.
Can some of the ways, that was a really good question that I just my words left me for about 10 seconds there. Can the delivery method affect how good I'm feeling? In other words, if I'm doing injections, can that have anything to do with it, or the creams?
It can. It can. Like if you use a cream versus an injection, a cream is going to convert a little higher to something called DHT in the body. It is the more active form of testosterone, but it also can cause more side effects. So if you are an individual who has a high rate of conversion from testosterone to DHT, then you may feel your testosterone more. Therefore, we have to be careful with any kind of side effect. And so, we talked a little bit about binding proteins, and you even mentioned about the hair on the fears around the hair on the face or the deepening of the voice. Or DHT is another one of those things that we have to look at if someone is experiencing something that is unexpected.
Can it create hair loss too? Can it create hair loss?
It can, but we also have data around where it doesn't. And so if someone comes into me and says, I'm on testosterone and I feel like my hair's thinning, I'm going to listen to that patient because I believe them. I also believe that it doesn't in certain individuals. So again,
is there things you can do to mitigate that or to manage
there
that?
are products that women can use to help strengthen or, make their hair more full. But we also have to look at the fact that in menopause, women lose more hair in general. And so about 50% of women will struggle with hair thinning in menopause. And then we see a lot of GLP-1 users. And so GLP-1s long-term can cause hair loss. So, we have to tease out what actually is the cause. Is it low iron? We see a lot of low ferritin levels leading to hair loss. And so a lot of times women in menopause struggle with a lot of these same things, and we have to tease out which one is it.
You're not checking the ferritin levels, and you might just attribute it to testosterone and stop it, and all of a sudden it was something else completely different.
Right. Or maybe you've lost a lot of weight. Maybe you have, we see hair loss after pregnancy, right? So we see it with a sudden decline in hormones. So maybe you had hair loss when you suddenly went into menopause.
And if you're not being tracked and have a care provider, then all these things you're trying to guess.
Right.
And you don't feel like
Right.
a
And
place
you
to
really
be.
have to listen to your patient too. If your patient says, I started testosterone and a few months in, I feel like my hair is thinner, then I'm going to listen to that and dig a little deeper because maybe it is, but maybe it is not.
Or
And
if it
so,
is, maybe it's something else to the iron. Let's go check
absolutely.
other things
Yes.
before we just stop doing the thing that may be working.
Yes.
Can we spend just a few minutes on, and I had no idea how this works because I don't wear a white jacket. I've never been to school for this, but pelvic floor, GUI, all these things. Did I get it right? Or so you looking
Yes.
at? But there's these things. I got sent a couple of articles about incontinence
Mhm.
and pelvic floor and testosterone. Is that a real thing? And then if so, what should women look for and how do they approach that?
So we see a lot of urinary changes in hormone decline. So in perimenopause, menopause, we see more urinary leakage, and GUI, genuine urinary incontinence, would be that I got to go right now. So that's urgency. That's that, I can't make it to the bathroom. Then we have stress, urinary incontinence. That's more of your like cough, sneeze, laugh. So it's more
Is that the pressure on the pelvic floor?
Pressure on the pelvic floor. And so there's some studies around looking at testosterone because there are androgen receptors all throughout the pelvis. And so we know it impacts the way our bladder health is. It's also correlated to our muscle strength in the pelvis. And so we know that testosterone, when you have a level that's lower in the range, so still normal, but low in the range, you're going to have more of that cough, sneeze, laugh. And so it's been associated with that. Again, more studies needed.
That works.
Well, you have those receptors throughout your body.
Yeah.
Testosterone receptors are in your brain, in your bladder, in your pelvis, in your eyes. We have testosterone receptors all throughout, just like we do estradiol receptors. And so when those levels are low, we have less strength, perhaps, or, we lose those signals. And so the bladder health, the muscle strength is going to weaken. And then over time, we see that. Now, again, we need more studies. We need more of this, but that's what the data is showing.
Well, the reason I keep checking my phone is I get questions. The people have my cell number.
Well, I want to say this about that too before we move on. You really need to, if you're struggling with urinary incontinence or pelvic floor dysfunction, a pelvic floor physical therapist is key. They can help identify those areas of weakness. So, having a good pelvic exam and working with a physical therapist can help you know which am I struggling with and maybe what could be a reason for it. We're actually having an event tonight. That's why I stopped you, because I was like, I want to get a plug in for our event.
Yeah.
We are having a free event for the women in Chattanooga at our studio off Lee Highway. We're hosting a pelvic floor physical therapist. She's going to do an event around pelvic floor. It's at 6:00 tonight.
So if you're on Lee Highway and you're going past Nutrition World, if you take a right onto Vance Road, if you're coming from 153, or take a left onto Vance Road, if you're going towards 153, then right behind there on that back road, Optimize You is right behind, literally smack down behind Nutrition World, and their studio, if it's the really nice one you're doing, is going to be in about 2 doors down on the right.
We'll have something.
Yeah, but it's
look for something.
6:00
free.
Is it going to be online or just in person?
Just in person. Dr. Erin Wessner, she's the owner of the Pelvic Method. So she started her own business around pelvic health, and she's going to talk all around how we can protect our pelvic health as we age.
Is she a local provider?
Yes.
Okay, good. So if someone hears this and they can't make it to the event, but they want to go check her out, they can also reference that they have.
Absolutely. Absolutely.
And you would recommend it for this kind of issue.
Absolutely. She is wonderful.
Because there's things you can do other than testosterone. There's things you could do, I'm assuming, just and the other thing too, I've learned this the hard way with hips and all these stabilizing muscles. And yes, my pelvic floor as you get older. If you think you're strong and you work out all the time, you may be. That doesn't always translate over and look like a strong pelvic floor or stabilizing muscles. You can be jacked.
Yeah.
And go, but you have weak muscles in certain places.
And we hold a lot of stress and tension in the pelvis. And so that tightness can lead to back pain, lead to chronic, pelvic pain.
Hip pain, all kinds.
Hip pain. Yeah. So she's going to talk a lot around that. Even there's a connection between the jaw and the pelvis. And so she'll talk about that tonight. We also know that testosterone helps with pelvic organ prolapse. So if a woman is having, to prevent pelvic organ prolapse. There's some new data around how testosterone will help with that. We know vaginal estrogen helps, but we are now seeing that data with testosterone as well. So there's a lot of new data coming out. It's really hard sometimes to keep up with. And it's important that, we seek these answers outside of just our general, online search.
Well, so my question to you as we get ready, and if anybody's got any more questions or thoughts, just feel free to chime in. Maybe you want to tell us how the therapies or hormone therapies helped you, but where's a good source? Because if I don't, from what you've said, there's not a lot of research, or if the research is going on, it's in the ongoing stage, and people aren't going to release how research went last month.
Right.
They're only going to release it at the end of big studies when it's been peer reviewed and all that. You can go find influencers, but influencers, again, may also be taking other things other than hormone replacement therapies, right? Or they may not be tied in with in other words, they may just not always be giving great information. Sometimes they do.
Yeah.
I follow a lot of people and I trust them. I go research it on my own. Is there places you go? Are there sources that you go, stay up to date with as much as possible and go to these 2 or 3 places?
Well, I do a lot of searching on PubMed. They're going to publish the latest studies. So that's going to be your scientific studies, which is, kind of like the gold standard a lot of times. And you have to look at the type study that is. That gets very technical. So looking for an expert in the field, like I follow Dr. Kelly Casperson, Dr. Rachel Rubin, I mentioned them earlier. There's Dr. Ira Goldstein. These are all urologists in the field of women's pelvic health and sexual health. They're on social media. They also have websites. They have books they've written, podcasts. There's also Dr. Mary Claire Haver. There's Dr. Heather Hirsch. There are a lot of thought leaders in the women's health space now that I feel like are reliable. And if you need resources, you can always reach out to us and we can point you in that direction.
Yeah. Is there anything else about, because I know you brought in some notes, you've not used it. You've done a great job, by the way.
Well, good.
You have. And I really want to make sure that the one serious question we got, I will do my best to find something.
Yeah, we will have to do a little digging on that just to see. And sometimes it's the opinion of one specialist versus another.
And until you hear different, trust your doctor.
Absolutely. Absolutely.
They don't know you. I know you, but we don't know your medical history.
Right. Absolutely.
Yeah. But also, if you would like to talk with somebody, feel free to make an appointment. I mean, they can make an appointment with you too and come in there and talk with you and bring all their test results and you can have the conversation with them. Is there anything else you brought in that you want to make sure we talk about when it comes to testosterone specifically in women? We've talked about how it's important for their strength. It's important for their brain fog. It's a mystery. It's like putting together this cog, all the hormones working together. We've addressed some fears, the pelvic floor. Anything that we've missed that you think is important for women to know, because this is a world you have been through and that you live on a daily basis?
I think the upcoming research is really exciting around the brain. So Dr. Lisa Mosconi is a neuroscientist. She's done a lot of work around estradiol in the brain, even developed a tracer where you can watch and see what the lack of estrogen in the brain does to women. And so it's correlated to all those symptoms of brain fog, losing your words, not being able to articulate what you think or feel, anxiety. And we know in women we have double the amount of brain disorders. So autoimmune conditions, brain tumors, Alzheimer's disease, dementia. And
double in women?
Double in women.
Even Alzheimer's? Really?
And we know that there is a change in midlife that now they're really starting to focus and look at. And her next area is looking at testosterone. So testosterone improves blood flow. So it also improves gray matter in certain age groups of both men and women. So when we're looking at those areas of the brain that are impacted by things like dementia and Alzheimer's disease, and I just mentioned this because it's new data and it's exciting. And I think in that world, we need some hope. And I love that we've got people really focusing their whole careers and attention on women with Alzheimer's and dementia. But she's now looking at testosterone and the role that it could play in blood flow. So, I'd love to see more data around that. And I think that that is an area that would really add to our validation of why testosterone is important for us.
I would love to get one of the people that you follow on a podcast like that.
Oh, me too.
So you've got some credentials.
I'll give you their name and you get them. On here, Clint.
Yeah, I could, but I would reference you because you're in the world. You would probably bring a little clout to it if they go, I'm sitting down with someone else that can speak the language.
Right.
This is awkward enough for me already to try to talk about something for women's health.
Oh, you're doing a great job.
I appreciate it.
Thank you for bringing attention to it. You know,
I appreciate that. I always try to think that because I was, I've got a great mom, got a sister, got women in my life and everything. But a lot of these conversations I have and the last few months on this kind of stuff is because I've listened to other people talking like, hey, this is just as important to us. And again, back to, as we circle back and close it up, it's not even approved for us.
Right.
It's just this craziest.
Right. And
that's
I would,
the nuttiest thing in the world.
Yeah. And I think I would just say for women to, advocate for yourself, for what you need. When you go in to meet with your provider, whoever that may be, take the information. If you don't know it, ask, because we have to have these open discussions between not only our provider and patient, but ourselves with our partners and our families, because we won't learn if we put ourselves in a place where we are afraid to ask the question, or we feel like we're not normal because we're experiencing some things. I can promise you someone next to you is experiencing the same thing. And so I would say, don't be afraid to ask the question. Good scientists ask questions. So as a provider, I would say continue asking questions. If you're a provider and you want more data, keep learning or send to somebody who's an expert, And so my encouragement to women of all ages would be, never stop learning and never stop asking those questions that can improve your health, not only for you, but for your sister, for your daughter, for your mom, for the next person.
Yep. All right. That's fantastic. It's Laura from Optimize You of Chattanooga. I think you did a fantastic job.
Well, thank you. It was great to be here.
We'll try to come up with a different topic.
Let's do it next time. Yeah.
We'll do something just as
Send us some topics.
Time. Yeah. Send us some topics and we'll do it. And if you need to make an appointment, you can go to Optimize You Chattanooga, find them online. Laura will be happy to meet with you. She's got the time and the bandwidth for new patients. And if not, we'll be sharing more stuff at the Nooga Podcast Network. Thank you, everybody.
Thanks, Clint.
Bye, Laura. We're out.